Good afternoon. The Nuclear Cardiac Society have asked me to provide you with some education on the role of multimodality imaging in cardiac sarcoidosis. My name is Eleanor Wicks and I'm the clinical lead of the Cardiac Inherited and Acquired Conditions Service in Oxford. And over the next half an hour or so, I'll talk you through what cardiac sarcoidosis is and the role of multimodality imaging in the diagnosis of this condition. And we'll take you through separately both the dietary preparation protocol that's critical for scanning in this condition, as well as the scanning protocol and how to interpret the images. I'll also touch upon the role of hybrid imaging in cardiac sarcoidosis and in the role of multimodality imaging in the prognostic evaluation. Finally, I'll provide you with some future directives that may be helpful for practice daily. So what is cardiac sarcoidosis? So cardiac sarcoidosis is a condition that generates an enormous amount of interest, but yet fear and anxiety in both healthcare providers and sufferers alike. It's a heterogeneous, multi-system, non-caseating granulomatous inflammatory disorder, which commonly affects the lungs, but can affect any organ, including the lymph nodes, the eyes, the liver, the heart, the nervous system, the musculoskeletal system, the kidneys, or even endocrine organs. Studies suggest that 5% of patients demonstrate overt cardiac involvement, yet autopsy studies report subclinical involvement in between 30% and 80% of cases. That's a vast statistic that really suggests and highlights that cardiac sarcoidosis remains a real and very significant challenge. Moreover, the lack of a precise and consistent case definition, variable methods of case ascertainment, and variability of disease presentation and progression all lead to the under-recognition of this condition and often its misdiagnosis. Furthermore, the lack of a sensitive and specific diagnostic test in detecting preclinical stages of disease, or indeed those at risk, really remains a significant challenge. So how do patients with cardiac sarcoidosis present? So cardiac sarcoidosis commonly affects the young, and often women more than men and blacks more than whites. It can present in many, many ways, including with acute arrhythmia or conduction disease, heart failure, or sudden death. Sudden death commonly occurs as a result of tachyarrhythmia or conduction disease, accounts for up to 65% of deaths from sarcoidosis. Extra beats within the heart are reportedly extremely common. Extensive infiltration may present as congestive cardiac failure or indeed dilated cardiomyopathy. Valvular heart disease due to infiltration or papillary muscle involvement by sarcoid granuloma can lead to left ventricular systolic dysfunction as well as valve dysfunction. We can also detect aneurysmal formation or dilatation, again due to the persistent fibrotic pathway associated with this condition. And sometimes infiltration of coronary arteries can cause coronary spasm or indeed can stimulate angina or an acute myocardial infarction. Chronic lung disease that arises with advanced fibrotic processes can lead to cor pulmonale and may result in right ventricular hypertrophy. And pericardial effusion similarly can be seen, although these are slightly less common. The clinical manifestations of the condition most primarily reflect the location and the extent of granulomatous infiltration and the pathological stage of disease, whether it be during an acute inflammatory process or fibrosis. As seen by this diagram here, we can see that there are two clear pathways. And if we focus on whether or not we can utilize the underlying histological pathway to identify active inflammation or indeed tissue scarring, then we can then try and adapt our imaging portals to assess both this inflammation and scar processes. So how do we diagnose cardiac sarcoidosis? So most commonly, the endomyocardial biopsy was the diagnostic gold standard. However, there are a number of errors with regards to the patchy nature of the distribution of this condition, which can affect both the endocardium, but also the mid or the epicardium. And the diagnostic hit rate, therefore, from biopsy alone is actually really quite low. Moreover, there's a complication rate of causing significant injury both to the heart muscle and to the vasculature more widely. So biopsy on its own is quite challenging to perform, particularly within the heart muscle. Most commonly, we try to target an extracardiac site, such as a lymph node, for example, to try and gain a histological diagnosis, but biopsy is far from ideal. So instead, we commonly utilize the Japanese Ministry of Health and Welfare guidelines to try and detect both histological diagnosis and a non-histological diagnosis suspicious of cardiac involvement. And as represented on the screen here, these include major and minor criteria on the left-hand side that you'll be able to see, both demonstrating advanced conduction disease or thinning of the interventricular septum, but also abnormalities on nuclear imaging and LV systolic dysfunction. The more recent Heart Rhythm Society criteria for diagnosing sarcoidosis looks at the histological confirmation of extracardiac disease and the presence of either a steroid-responsive heart muscle-related problem, heart block, for example, LV systolic dysfunction, or unexplained sustained ventricular tachycardia. It also focuses on the role of patchy uptake on cardiac positron emission tomography, or the SCAR pattern on cardiac MRI scanning, or the role of a gallium scan abnormality being detected. But we utilize these quite commonly in clinical practice as they help us identify, they try to help to depict and identify whether patients may have these conditions or not. But most commonly in this, the focus of this talk today is the role of positron emission tomography and late enhancement, particularly on cardiac MRI scanning. So these two diagnostic guidelines are very helpful clinically, but they've never actually been prospectively or clinically validated, and they have very little supporting randomized data. They also don't consider cardiac sarcoidosis as an isolated diagnosis, which can occur. Moreover, the Japanese guidelines have a very low diagnostic sensitivity. The Heart Rhythm Society guidelines are very helpful in that they include positron emission tomography and an immunosuppressive responsive cardiomyopathy. But again, these require further evaluation. Let me take you through some clinical examples. So the first is a 42-year-old lady that presented with breathlessness predominantly and some sweating. She had symptoms of NYHA class 2, and she'd noted some weight loss. On clinical assessment, she had bilateral lymphadenopathy, as you can see on this chest radiograph, and she had some conduction disease with bundle branch block intermittently on her ECG and Holter monitor. She had quite prominent atrial tachycardia and almost an atrial arrhythmia, which was really quite unsettling for her. She went on to have an echocardiogram, which demonstrated LV systolic dysfunction with an ejection fraction actually calculating at around 30–35%. She went on to have some blood tests, which demonstrated a normal serum ACE level, but she was interestingly noted to be lymphopenic. Her calcium level was very high and she had mild renal dysfunction. She therefore went on to have a renal biopsy and a cardiac MRI scan. Although interestingly, her first cardiac MRI scan did not demonstrate any evidence of late enhancement or fibrosis. However, her renal biopsy did confirm a non-caseating granuloma, which was suggestive of sarcoidosis. So given her presentation with breathlessness and LV systolic dysfunction, we wondered whether she actually had cardiac sarcoid. However, given her cardiac MRI scan did not demonstrate late enhancement or T2 abnormalities on imaging, we weren't quite sure as to whether or not this was evidence of active sarcoid or not. She was, however, empirically treated with steroids primarily because of the renal dysfunction, and we commenced her on disease-modifying treatment for LV systolic dysfunction. Following 12 months, her heart function had improved, her kidneys had improved, and her calcium level had normalized. She was therefore weaned off the immunosuppressant therapy. Unfortunately, however, shortly thereafter, she deteriorated in cardiac dysfunction and became breathless again, and again had symptoms of NYHA class 2 to 3, suggestive of LV dysfunction. So she underwent a cardiac PET MRI scan. We were very fortunate at UCLH to have this technique available at the time, and so we sent her for this scan. And as you can see, actually the LV function in the functional imaging wasn't too bad. But her stir imaging looked normal. Indeed, her imaging on late enhancement demonstrated this small patch of fibrosis in the lateral wall. And similarly, in the 4-chamber view again. But when we looked at the PET image, we could actually see that there was evidence of an acute patch of acute inflammation in this lateral wall in the area around where the late enhancement was. So this helped us guide that this lady had cardiac involvement, and she really had quite extensive late enhancement laterally, but an absence of edema on T2 weighted imaging and stir imaging. So that was actually quite interesting, because without the overlying PET to detect the active inflammation, co-localizing in the area of late enhancement would have missed this lady's abnormal active inflammation. As a result of these findings, she was recommenced on steroids, and we added in hydroxychloroquine, and her LV function improved dramatically. Indeed, she also settled her atrial arrhythmias, and she has since been maintained on a low dose of prednisolone and has been so on this for at least another 12 months since. Another case example was a 33-year-old lady that presented with a 4-week history of acute palpitations, previously been very fit and well, and she found to have ventricular tachycardia on her ECG. She went for a PET MRI scan first off this time, as this has become more routine in our clinical practice. And as you can see here, again, there was very little suggestion of abnormality on edema stir imaging, but she had this quite extensive patch of late enhancement suggestive of fibrosis in the inferior wall. And when we added the positron emission tomography imaging on top, we were able to detect overlying what we thought was late enhancement suggested of scar, but with actually an increased evidence of metabolic activity in this infralateral area of her heart. When we added the colour SUV mapping images, not only were we able to see that she had both the active areas of inflammation within her heart, but we were also able to see the systemic involvement with lymph node involvement and indeed lung involvement, telling us that not only the pathophysiological stage of the disease, but also the extent of the extracardiac involvement that she had. We went on to confirm a lymph node biopsy histological diagnosis rather than a cardiac biopsy diagnosis, which confirmed sarcoidosis, and she was commenced on immunosuppressive therapy. Unfortunately, despite quite aggressive immunosuppressive therapy, she really had quite intractable ventricular tachycardia, and it required a very long course of immunosuppression. She had a device, an intracardiac defibrillator device implanted to protect her from the ventricular tachycardia, but her disease activity really became very, very prominent. She suffered a number of complications due to weight gain as a result of prednisolone therapy, but finally, after 3 years of aggressive treatment, she went into remission. So those case examples have touched upon the value and benefit of both positron emission tomography and cardiac MRI, but let me take you through these in more detail. So the etiology and pathogenesis of cardiac sarcoidosis is unknown, but environmental, occupational, infectious, and genetic predisposition elements have all been implicated. What we notice that cardiac alterations in the cardiac structure and function are often attributed to an exaggerated abnormal response of the immune system, leading to inflammation or scar, as demonstrated in this picture. The histological hallmark of disease is the sarcoid non-caseating granuloma, which consists of an aggregate of mononuclear phagocytes surrounded by a rim of CD4 T lymphocytes. Early in the diagnosis, patients demonstrate a heightened T1 helper cell immune response and cytokine profile, principally secreting interleukin-2 and gamma interferon. Later in the disease, however, there is a switch to a type 2 helper cell response with fibroproliferation and tissue scarring. If we utilize these, we can actually use PET scanning to identify and detect areas of inflammation, and similarly MRI scanning to detect the scar processes that we often see within the heart muscle. So, cardiac MRI scanning in cardiac sarcoidosis. So MRI scanning is extremely helpful as it allows us to detect both inflammation within the heart muscle using T2 stir or T1 and T2 mapping techniques, looking for edema, but we can also assess and look for areas of necrosis and fibrosis within the heart muscle. So it's an extremely invaluable assessment for detecting both clinically cardiac sarcoidosis and myocarditis more broadly. The position statement on imaging in cardiac sarcoidosis was recently published in 2017, which again highlighted the roles for morphological and functional evaluation, as well as T2 evaluation and late enhancement imaging. And all of these techniques are really, really key. Why? Well, as I've mentioned, T2 helps us identify active inflammation or edema within the heart muscle. The early and late gadolinium enhancement techniques can detect scarring, and we can look at the functional evaluation, perfusion evaluation, and an anatomical evaluation. And it can help identify both the extent of organ involvement, but also the active or the inactive stage of the disease. Our cardiac MRI scanning is similarly extremely highly sensitive, and provides us with a really good resolution. There are some disadvantages in that if someone has a device, it can lead to artifact, and many centres do not yet scan those with device therapy. There are some limitations with regards to end-stage renal impairment, particularly regarding nephrogenic fibrosis, and protocols can be time-consuming. However, the pattern of late enhancement or proposedly scarring within the heart can form any pattern, really. So if you have something that you're not sure about, anything can pretty much relate to sarcoidosis. But still, extensive cardiac involvement and extensive patterns of scarring could represent sarcoidosis. So it's always something to think about. What about PET? So positron emission tomography is a technique that tries to identify any increase in physiological function, such as an increase in metabolism as seen in cardiac inflammation, because we can target this and we can image it. Positron emission tomography in sarcoid imaging utilizes the glucose analog and radiotracer 18-FD FDG fluorodeoxyglucose to detect active inflammation. FDG is injected and can be taken up by macrophage or inflammatory cells in sarcoidosis. And after crossing the cell membrane via glucose transporters, both 18-FDG and glucose are phosphorylated by the enzyme hexokinase. While glucose is further metabolized, the phosphorylated 18-FDG remains trapped within the cells and tends to lead to an accumulation of tracer, which decays over time, emitting photons, which can be detected by can be captured by the detectors to form images. Active inflammatory cells have a high glycolytic activity to sustain their large energy demands, and as a result can produce ATP levels that are almost 8 times higher than baseline. The accumulation of the FDG in these activated macrophages and CD4 T lymphocytes, therefore, is the mechanism for visualization of active granulomas. So, taking things a step further, what is PET-CT? So PET-CT is a non-invasive whole body molecular imaging technique integrated with CT, computed tomography, that uses the radiotracer 18-FDG to act as a glucose analog to examine metabolic pathophysiological processes. This technique is well known to detect higher molecular and metabolic rates, such as seen in cancers. So with this technique, really, we're wanting to detect inflammation, to detect disease presence and extent, and to guide therapy and therapeutic options, potentially to guide histological diagnostic evaluation by targeting biopsy, to improve the diagnostic yield for cardiac sarcoidosis, to monitor disease progression or response to treatment, and potentially for prognostic evaluation. And research has demonstrated really that there is a huge potential contribution that PET can make in this condition to identify those that have a condition and to detect those that may lead to adverse clinical outcomes, or those that may be at high risk, to target device implantation and again to better guide our prognostic evaluation. However, positron emission tomography using FDG can be limited. So there really is a peculiar patient presentation that all must undertake to minimize physiological uptake within the heart muscle, because naturally the heart's a very metabolically active organ, and so we have to try and figure out how to switch off normal metabolic activity to ensure that we can see the extra super added activity that may be associated with myocardial inflammation. Moreover, we don't have a significant amount of information about whether PET provides diagnostic value in other cardiomyopathies, not just myocarditis or sarcoidosis. Furthermore, there is radiation associated with PET-CT, and it's relatively limited in its availability and accessibility. There are many other technical aspects to consider as well, which falls part of the physics component of the technique. How do we optimize PET scanning? Well, we utilize a preparation requirement really that follows an Atkins diet. So we recommend very much so that people take at least a 12-hour fast immediately prior to scanning. But for the time period for 24 hours before this point, we recommend a high-fat, low-carbohydrate diet, otherwise known as an Atkins diet. And then immediately before the actual scan is performed, we inject heparin, because heparin can help activate lipoprotein and hepatic lipases, which can can almost promote the heart to use fat as a fuel. And some of our preliminary data has demonstrated that these techniques are absolutely fundamental, because we can improve the success rate of dietary preparation, whereby we can suppress physiological uptake dramatically in 92% if we adopt this heparin, high-fat, low-carbohydrate diet and a fast technique, versus only 50% success rate if we use just a 6-hour fast alone. So it's absolutely critical that dietary preparation is undertaken for this scanning technique, which can complicate the scanning protocol and procedure. Following the dietary preparation, we recommend a restful period for people to relax, because even talking can make the vocal cords go light, can brighten up, but also the heparin 15 minutes prior to FDG injection. The image acquisition takes around 60 to 90 minutes. So we take the images around 60 minutes after the injection of the FDG to allow time for the heart to take up the tracer. And then we image the whole body from head, vertex to thigh, ideally alongside a high resolution CT scan to provide accuracy in evaluation of the lungs. Many centres will also use myocardial perfusion SPECT imaging as well to help guide perfusion evaluation, to help in the evaluation of these conditions and the scan outcome. How do we interpret the scans? Well, we classically use the LV segment model, the American Heart Association 17 segment model for myocardial segments, to look at a segment by segment analysis and region of interest. As you can see on the right here, we can see 4 common patterns of FDG uptake: complete suppression in the bottom left, a failure to suppress the myocardium with overt diffuse uptake, which we would recommend as a failed scan in this process, or we may see a patch of focal inflammation, as in the bottom right-hand image, or a focal on diffuse pattern where there is a slight uptake across the whole of the myocardium with a more focal element, as seen in the top right-hand corner. The 2 focal on diffuse or focal inflammation are often normally characterized as an abnormal scan result, suggesting disease activity, whereas those on the left normally are categorized as a negative scan, although they do have to be taken in context. And if you have someone with diffuse uptake, it is important to assess whether there are any other extra cardiac involvements, or whether they may have extremely extensive cardiac involvement, as there is potential for false negatives if we concluded that a failed suppression scan was truly negative. So what's the diagnostic sensitivity of cardiac and PET scanning? Well, as this table illustrates, there are a number of studies now that have been performed using different dietary preparation techniques, but overall the sensitivity and specificity are pretty similar throughout. Both PET and MRI are highly sensitive techniques, and slightly less so in specificity. But as I've mentioned, these are quite a few studies now, so they really do corroborate that the use of PET and MRI is extremely helpful. Perfusion imaging has also been helpful to guide both diagnostic and prognostic evaluation, which I'll come on to shortly. As you can see in this diagram, we are able to look at both in the top panel there, we can see the MIP imaging suggestive of mediastinal systemic sarcoidosis, but the absence of cardiac involvement, and similarly in the overlying middle layer images there. If we look at the bottom two rows, there's both the patterns of MPI and FDG uptake are demonstrated in the top row with rest MPI and FDG on the bottom row. So if we look in example A there, we can see that there is no FDG uptake, so the uptake is normal, and the perfusion imaging is also normal. So this is classified as a normal pattern of uptake with the absence of cardiac sarcoidosis. In contrast, if we look all the way to the right-hand side, we can see that there is what we suggest is an area of fibrosis in the infralateral wall of the heart, but actually the corresponding FDG demonstrates pooled activity, suggesting that, again, this scan looks normal, aside from some scarring. However, if we look at B, B is diffuse, both diffuse uptake and diffuse normal homogeneous myocardial perfusion imaging, suggesting non-specific findings, but nothing grossly abnormal. But if we look at the patterns with both C, D, and E here, we can see that not only is there increased FDG uptake consistent with active inflammation within the heart, but we can also see patterns both in C with the absence of fibrosis on myocardial perfusion imaging, perhaps a small patch of diffusion defect beginning in D, but certainly not significant. But indeed in column E there, we can see not only the area of increased uptake in the FDG parameter, but also a perfusion defect in the upper image, suggestive of active inflammation that has caused an area of scar. What about hybrid imaging? So I've touched on MRI on its own and PET on its own, but hybrid imaging offers a capability for a one-stop shop of evaluation both of metabolic disease activity, functional related activity, and the evaluation of tissue characterization and scar. It doesn't add additional radiation to the separate techniques, and it allows us to have simultaneous imaging to know at the same simultaneous time what the metabolic and scar-related functionalities represent. Simultaneous acquisition reduces the time for these overall separate scans. It's an improved technique for patients. They prefer coming for one scan rather than having to come back for multiple appointments to the hospital, which improves efficiency and throughput through the departments. It also allows us to offer the gating, respiratory and ECG gating requirements, and to optimize attenuation correction or motion and partial volume correction, albeit there are still some challenges with regards to attenuation correction. Finally, it allows the temporal correlation of both the PET and MRI data, as I've mentioned. But it can be extremely helpful to detect active disease, acute versus chronic or inactive disease, and to assess the severity of the disease, the extent of the disease, and the extracardiac involvement of the disease. And it can help us interpret and differentiate cardiac sarcoidosis from other cardiomyopathies or other conditions. As I'll come on to, it's extremely helpful to guide treatment and to risk stratify patients. And this is the classic technique that we use, where we set the PET bed running in the background, and then we look for, we do localizers and assess extracardiac anatomy while looking at wall motion, areas of inflammation or edema imaging, and scar-related imaging. I'll walk you through some of the results that we found in preliminary data, which have demonstrated both the patterns of PET uptake within the heart muscle and areas of scar predominantly locating themselves to the basal anteroseptum and the infralateral wall. Interestingly, does evidence of FDG uptake overlie or lie in regions next to areas of late enhancement? Well, we've seen a mixture actually. So both patterns can be seen where there's overlying, superimposed areas of presumed scar and inflammation, but equally there are areas where we will see a patch of scar surrounded by areas of active inflammation. So there's still a further amount of work to be done here. But what has been detected is that, again, the role of hybrid PET-MR is extremely sensitive, up to 94% in sensitivity, albeit at the expense of specificity. But again, extremely valuable technique in the detection of sarcoidosis. And essentially, if your PET MRI is normal, then the likelihood of you having sarcoidosis, or certainly cardiac sarcoidosis, is extremely low. What about prognosis? So in this small study of just 51 patients, of whom 7 had biopsy-proven, histological endomyocardial biopsy-proven sarcoidosis, and 44 of whom had systemic biopsy-proven sarcoidosis, over a mean follow-up of 2.2 years, 18 patients had events. That's 35% of the population. Indeed, 37 people were on immunosuppressive therapy. But if we look at the pattern of uptake that was detected, 28% of those with focal uptake of those with focal uptake, there was an annualized event rate of 28%. Interestingly, those with diffuse pattern of FDG uptake had an annualized event rate of 24%. So what's going on here? Because focal uptake of 28%, but diffuse uptake of 24%, is diffuse uptake therefore not active sarcoid? Because traditionally we categorize those with no uptake or those with diffuse uptake as a false scan that we presume is a normal scan finding and just representing metabolic activity or a failure to suppress glucose uptake in this situation. But is this really what we're seeing? Interestingly, if you look to the right-hand graphs there, both graphs demonstrate survival and adjusted survival, respectively. And with PET abnormalities on their own, PET on its own doesn't detect a significantly adverse survival. But as we add PET and late enhancement abnormalities, this leads to a much more adverse survival than without. If we look at, specifically, if we look at potential multivariate analysis models to look at which variables may predict an adverse event, interestingly, RV avidity was predictive of an adverse outcome, yet cardiac PET findings on their own was not. However, in contrast, late enhancement was an independent predictor of major adverse cardiac events, irrespective of the model used. Other studies with regards to prognosis and PET scanning. So a big study by Blankstein et al. Back in 2014 in 118 patients demonstrated that abnormal perfusion and FDG uptake abnormalities predicted an adverse survival. Similarly, looking at late enhancement and prognosis, those with late enhancement also conferred an adverse outcome. And a number of studies have since demonstrated the same information, whereby both MRI and PET abnormalities are predictive of adverse events. So we therefore have it that the presence and extent of late enhancement can predict prognosis, that PET positivity, notably RV PET abnormalities, alongside resting perfusion defects most notably, are predictive of adverse events, and that PET and MRI abnormalities together worsen outcomes clinically. Left ventricular dysfunction and LV dilatation, as we would expect, similarly confer an adverse prognosis. And there's a discussion whether reduced global longitudinal strain similarly confers an adverse outcome. Interestingly, extracardiac sarcoid does not appear to be associated with an adverse event, although I think perhaps further clarity on this is required. Taking all of that information on board, how do we manage these people? So we always commence people with LV systolic dysfunction on disease-modifying therapy to support the left ventricle and to try and prevent adverse remodeling. And many, if we can treat this process effectively, can improve LV function, providing we are tackling the condition and treating it before they've developed significant scarring or end-stage fibrotic disease. However, when do we know who and when should we implant a defibrillator within? Sometimes we do an EP study to try and see whether someone is at an arrhythmic risk. However, the guidelines currently recommend that if your pump function is less than 35% after immunosuppressive therapy, that you should have a defibrillator implanted. Furthermore, we may consider, if there is a burden of scarring with an LV that is not entirely normal, that again, we can consider device implantation. And how we use things practically is we often repeat PET scanning following immunosuppressive therapy after initiation to see whether there is improvement in both the extent and the severity or indeed resolution of active inflammation on PET scanning. So to conclude, cardiac MRI offers a functional and morphological assessment with tissue characterization, but it can, as I illustrated in the first couple of cases, it can miss disease presence and activity. The frequency within which this can occur is yet to be understood and determined, but my guesstimation is it's around 25%. Late enhancement cannot differentiate between active disease and chronic scar, as we've seen in the cases where there was overlying FDG activity and late enhancement. T2 stir is unreliable, and parametric mapping techniques are required and hopefully will improve the diagnostic accuracy and clinical evaluation of people with cardiac sarcoidosis. In contrast, PET can detect active disease, particularly that missed on cardiac MRI scanning, and can also be very helpful in those with devices whereby the parametric MRI techniques may be unreliable as a result of device artifact. However, multimodality imaging using PET and MRI combines these techniques and really does enhance the diagnostic potential and the potential to guide disease pathophysiology and disease staging and potentially disease adverse outcomes. So hybrid imaging holds major promise in the diagnostic and prognostic evaluation of cardiac sarcoidosis. Please note that dietary preparation is absolutely critical. It does offer improved diagnostic accuracy for detecting cardiac sarcoidosis, and as I've demonstrated, can guide prognosis. It prevents the need for two separate scans, improving efficiency and flow through our clinical departments, and it can assess and guide extracardiac disease, which we can use to target biopsies. Furthermore, we can use both PET and MRI to monitor efficacy of treatment and to assess disease progression to guide both pharmacological and device therapies which may be required. What we do is need further information to better understand how to quantify disease, and there have been some recent studies in evaluating quantification of positron emission tomography abnormalities, which I've not gone into in the interest of time today. But again, this may help our understanding in detecting who truly has a false positive scan whereby there was diffuse uptake within the heart. We have a lot more work to do, and we must examine PET abnormalities in other conditions. We need to further evaluate the role of diffuse uptake, as I've mentioned, and we should look to perform studies to see how long we should be treating people for following a hot scan. When should we re-image? What are the temporal changes that may arise with disease evolution? And to assess the cost effectiveness of these imaging modalities, which are not always readily available. Furthermore, it's really helpful that we examine the use of hybrid PET-MR in other conditions beyond cardiac sarcoidosis and inflammatory conditions, both to endocarditis, examining it in ischemic heart disease, and potentially other cardiac conditions. Thank you very much.